with all due respect.
Hey, we're Josh Ortegon and Gray Achille, and this is With All Due Respect, the show where we keep it real about health, fitness, and performance. From weight loss to sports development, we're covering the conversations that matter.
Follow us on Instagram at WaterXPod, WADR, and visit PhenomBrand.com, PHNM, for performance gear and training programs built for real results. Let's get into it.
All right, guys, here we are. With all due respect, 100 and something. I don't know. I've lost. When it was like, with all due respect, 7, it was a lot easier.
Mm-hmm.
And then now I feel like I'm no clue. But we're kind of moving forward on the women's health. I feel like we're back on the women's health. Like
I think we'll always be on the women's health.
We did a long story, and we've had so many in women's health, and I let people know, like, hey, I'm just kind of going to sit here and listen, because my experience with women's health, it's maybe from an orthopedic surgeon coming on, is more like the ACL side of rehab and return to play performance. But I'm going to try to pronounce your last name, and I'm probably going to mess it up.
You have a 50-50 chance.
I do. I do. It's so crazy. It's so crazy you say that. Yesterday, I was kind of looking you up, researching, and kind of seeing what you are. And I go, well, you pronounce that name one of 2 ways.
Mm-hmm.
And then when he told me, and Dr. Jocelyn Wittstein.
Oh, you got it wrong, but that's good.
Oh my God. And you know what? I was gonna go with Stein, and then I was like, I totally doubted myself, and I went the other direction. So it just proves we should go with our gut.
I know.
I know.
No one ever remembers, and I don't bother to correct people because it's recognizable.
Yeah, I have my last name's Ortegon. I've heard it 1,000 different ways, and I tell people that anytime we had a substitute teacher in class, they looked at my last name, they're like, Joshua, or I'm just raising my hand. I'm here, buddy. I know what you're trying to say. Don't worry about it. Doesn't hurt my feelings. But I'm very excited to have this conversation, even as I kind of looked you up yesterday. And if you can just kind of give our viewers or our listeners a little bit of intro of who you are. And I have a feeling once you get 30 seconds into it, our listeners are going to be like, oh, this makes sense that they're on the show.
Sure.
Right?
Yeah. So I'm Jocelyn Wittstein. I'm an orthopedic surgeon specialized in sports medicine. I'm an associate professor of orthopedic surgery at Duke University. My subspecialty, surgical subspecialty, is sports medicine, but I have a lot of research interest at the intersection of women's health and musculoskeletal health, and also the female athlete across the lifespan. And so I do a lot of research on ACL injuries, meniscus injuries, post-traumatic arthritis, but also things like how, midlife hormonal changes affect risk of frozen shoulder or arthritis or bone loss. And my other sort of fun side hobbies are, I'm, an avid exercise enthusiast. I love nutrition. I studied nutrition as an undergraduate at Cornell. I'm co-author of a book called The Complete Bone and Joint Health Plan, which is sort of a resource for non-medical people to understand arthritis and osteoporosis, basically their musculoskeletal system. And yeah, I like to educate students, my residents, my fellows, my patients, the public.
Yeah. And I like how you said we had a conversation prior to recording, which always happens, man. We always have like the cool stuff, and I'm like, why didn't we hit record? But you said you were motivated or inspired to do content because of your daughter.
Yeah, I have we have 5 kids, but my 20-year-old daughter suggested to me a bit over a year ago that I should provide content on social media. And this is not an exaggeration. I don't think I had ever used the selfie function on my phone before, except for to cut my hair, because I cut my own hair in the mirror with my phone. That's the only time I would ever use it. But so she convinced me to do this, and the first couple of reels I made on Instagram, she filmed them for me, and she, like, explained to me the difference between, a reel and a story, and I was very confused for a month or so, and, at first I paid her, like, $50 a week to help me, and then she weaned me off of her, uh, you know, education on how to use, Instagram and then set me free. But well, she is the one, and it's funny because, kids these days, people of her age group, they do learn things from social media, and she suggested to me you should be on social media. And I actually just recently gave a lecture and a panel at our resident research day, which was the topic was translating science to the public. And
Oh, yeah.
in preparing for that lecture, some of the information I reviewed was, where do people get their health information? And a shocking amount of it is through social media. Um, but people also recognize that they're sometimes maybe not like totally trusting the source, or they have, a variety of sources that aren't necessarily people in medicine. Not that everyone has to be in medicine. Of course, there's people who are, there are professionals in other fields that have great contributions, like personal trainers and such as, like all those adjacent fields. But
Mhm.
there's just a lot of people who are consuming health information through social media, and for many people, it is their primary source. So I do think it's helpful for doctors to contribute to that, to be, if possible, a trusted source. Um, and so it's just the reality. It's kind of funny. I have a video on my Instagram about like how to properly wear your sling, and one of my patients was like, "Oh, I watched that video. I know how to wear my sling after."
Yeah. Yeah.
I didn't actually create it for my patients. I just created it because I thought, well, this will be useful to somebody. But and how to use crutches or how to use your polar care. Just those are kind of more orthopedic adjacent topics. But it's true. People get so much of their information on social media platforms.
Hmm.
As an orthopedic surgeon, one of the things you said that I knew I was already going to be all in on this. You said, so many of my patients come in, don't need surgery, they need education.
Hmm.
And for our general population of people that are listening, let's talk about specifically like osteoarthritis or osteoporosis or bone health or joint health. What are some of the assumptions that you have people come in and you're like, oh, we believe, kind of like you hear people say that in my industry, you hear people say, oh, weightlifting stunts your growth, right? You hear
Hmm.
that say young kids, or
Hmm.
weightlifting is bad for a kid's joints. They shouldn't start until they're 15. You hear those kind of, or Gray always talks about lifting weights for women. It's going to make you bulky, right? And
Yeah. I
people,
dare you to try to get bulky.
yeah,
Yeah.
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 Please, I wish it was that easy, right? Yeah, you're right. I dare you to go try to get bulky. Please take 3
I
years
try
for
every
a
week
female.
to get
I
bulky.
know it's not working, is it? You're not bulky,
Yep.
right?
Yeah.
And you hear people say that, and people just kind of say those things like they're truths.
Mm.
They say it like you're just going to nod your head. And you're like, "Oh, that's right." And you're like, "Actually, that's not true." What are some of those that you hear from women, women specifically, around bone health, bone density, osteoarthritis, that they come in and they just assume these certain things, and you have to unlearn them and relearn them? What are some things that you hear every day?
Yeah. And a little backdrop to the conversation we were having, you were asking me about like being in surgery or versus being in clinic. And I said,
Hmm.
surgeons are always going to say they like to be in surgery more than being in clinic because it's this like you're in the zone, you're kind of fixing things, you're making people better. It's very rewarding. But clinic is rewarding in a different way. It's not that I don't like being in clinic. I do many times like love interacting with my patients, but and then we went into this topic of that so many people that come into an orthopedic clinic actually don't need surgery. It's like the majority of people that come to clinic don't actually need surgery, which is where the education piece comes in because there are a lot of non-surgical interventions that we have to educate our patients if we're counseling them for surgery, but we have to educate them also about non-surgical approaches. And I think the most common sort of misunderstanding is that that uh, osteoporosis is something that will definitely worsen over time, or that there's like not anything you can, do about it, besides medication. Medications are often needed, but like if you have osteopenia, osteoporosis is not necessarily inevitable. There's a lot of information online about, um, women losing bone and how rapid and, all of the changes that happen in midlife, which is true for sure. And I do think it's important for people to be aware of that. These changes, these like the accelerated bone loss that happens a couple of years actually before menopause. But um really your bone health is modifiable, and a lot of it is modifiable through diet and exercise and lifestyle choices. It doesn't mean like someone with osteoporosis is not necessarily going to need medication, but there are a lot of um non-medicine interventions that can be made. And the other thing is I think that people um don't recognize that it's actually a win. Like if you have osteopenia and you can maintain your bone density but not progress towards osteoporosis, that's still a win because you are intervening with the natural process of gradual bone loss over time. So I think people sometimes feel like if they're not improving or gaining bone density, that they're not um being successful in their efforts, right? But like actually just holding steady that's good. That's a good thing. So there's a lot of just misunderstanding about like osteoporosis isn't inevitable. There are things you can do to intervene to improve your bone loss, or to improve your bone density, but you also like it's okay to kind of be maintaining what you have, that's not
Mhm.
that's not a failure either.
I say the same thing to people that come to me as they're aging and they want to improve their mobility and flexibility. I say, "Hey, just maintaining it as you age, you don't
Is
have to do
winning.
the splits."
Yeah.
Yeah, you don't
You
they're like,
we don't
you
need
know
you to do the
yeah, and they're
splits.
like, "Oh, well, what if I could one day do the splits?" I said, "What if we talk about, like, maintaining your motion and mobility
Mhm, mhm.
first? 'Cause, you lose so much of it as you age because you just don't move and do the range of motion and strength train as we get older." And, people always ask me, I've had people like, "Hey, what's your purpose of weightlifting in the gym and lifting the gym?" I said, "I want to lose muscle slower than any other person in history. That's
Mhm.
my goal. I want to as
Yeah.
I age, I want to lose muscle slower than anybody else I've ever met in my life."
Yeah, it's
Because
hard to
I mean,
gain
yeah,
any forever, like, eventually
you
it
don't
would.
have the hormone profile as a male, like it just changes over time.
Mhm.
And I said, "Well, so much research around longevity and maintaining muscle and I wanna stay functional." And I think there's a lot of people in my age bracket. Um, it seems like you hear these stories all the time. Late 40s and 50s are like the old 30s. Like you wanna maintain and be functional as you're old. Like I tell Rachel or I tell Gray all the time, like, I wanna be a little bit jacked in motion and playing shuffleboard in South Beach, Miami with white shoes and matching
In
track
your retirement home.
in my retirement home, but I kinda wanna be I wanna be a little bit jacked and be able to
Mhm.
move around and, if I trip and fall on the ground, I wanna be able to stand up. I don't wanna take, an hour and a half to get off the ground, and
Yeah.
I kinda wanna be able to play shuffleboard in my white shoes, my matching tracksuit, and still kinda be jacked a little bit and kinda move around, right? Like, I kinda
Yeah.
wanna do that because you see people as they get older, um, getting up and off the floor is a struggle,
It
right?
is, and yeah, like, I think, as you said, it's important to try to, like, maintain, but I think sometimes people can feel defeated if they're always trying to get back to something that they
Yes.
were,
Yes.
Mhm.
Oh,
and,
that's so true.
um
Yeah.
and so I think, your goals change and, you reassess and tweak a little bit as you age. I mean, I have tons of examples of this where I used to love to do like 3 sets of 10 pull-ups every day, and if I did that now, I would have actually really bad biceps tendonitis. So
I love
I
it.
can't do that many pull-ups because literally I will pay for it and I'll have biceps tendonitis no matter what it happens to me every time I build back up to that volume. And so I can't do that many. And so
Yeah, we were filming
that's
some
okay.
content. We were filming some content yesterday, and one of Grace's friends jumped up and goes, I can do 10 to 20 pull-ups. And I was like, if I did 10 to 20 pull-ups right now, I'd blow a bicep out. Like I'd rupture I would be one of those people coming to you that you looked at me, go, oh no, you need more than education. You need surgery too. Like that'd be, one of the topics that you talk about that I'm very interested in is the correlation to, I believe it was, perimenopause hormone replacement and frozen shoulder.
Mm-hmm.
Never in my life would I think that those two would have some sort of correlation, because I remember as a little boy going to the physical therapist with my mom with frozen shoulder.
Yeah, tons of
They actually
people, if you
thought
ask
about,
them, like if you ask people, like think of like many people will remember when they were a kid, their mom having frozen shoulder. And my mom had frozen shoulder. I've had frozen shoulder, it's extremely common in women. And the group it really seems to hit is kind of women between the age of 40 and 60. Um, and the reason I started thinking about it and studying it was actually first, it kind of dawned on me through, I have a lot of patients that have breast cancer, and a lot of them are on aromatase. I mean, I'm not a cancer specialist. I share these patients. They're my patient for various reasons, but um, they're being treated for breast cancer and they're on aromatase inhibitors, and aromatase inhibitors can cause a lot of joint inflammation and pain. They're basically, keeping testosterone from being converted to estrogen. So you're sort of
Mhm.
putting someone into a menopausal state acutely. And a lot of frozen shoulders in those patients. And then I started kind of thinking, well, like, the other group of people that have this are women really between the age of 40 and 60. And really, if you see a man with frozen shoulder, it's most likely they have some sort of endocrine disorder, like typically diabetes. Occasionally, I'll see a man with frozen shoulder after they've had like a major heart surgery or something where they were like maybe on an OR table for a long time with their arms in a certain position. Or actually, a lot of cases in men that are labeled as frozen shoulder are a little bit of early arthritis of the glenohumeral joint. It's not actually frozen shoulder; it's like a flare up of the arthritis. But women get this, idiopathic frozen shoulder, and if you really ask women like what else is going on, a lot of times they're also having vasomotor symptoms, hot flashes and night sweats. And so I started studying this and, proposing this connection, and we're still studying it. But I work a lot, like very closely with my women's health colleagues. And so, we've kind of more and more recognized this as a sign of perimenopause and the menopause. And so, I'm always asking my patients who present with this about their vasomotor symptoms or what else they have going on, their insomnia, things like that. I'm referring them to women's health. My women's health partners are recognizing that when they have a patient, who's having a lot of menopausal symptoms, and they're recognizing the frozen shoulder and they're sending them to me so that we can, treat them earlier. And I have some upcoming data I'll be presenting at a meeting in July that like kind of continues to sort of support this connection. But it's really probably, there are other changes that happen in midlife as well, like hemoglobin A1C will creep up a little bit. There's a little bit of worsening of insulin sensitivity. There's more and more information to suggest that, estrogen has an effect on the capsule of the shoulder joint by inhibiting cells called fibroblasts, which are like these cells that sort of thicken the lining of the joint. And then there's probably a bit of overlap of endocrine changes as well. So yeah, it's certainly a condition that has been primarily seen in women, since it was named, and it's been
Yeah.
considered idiopathic. And I do think that sometimes when things are considered idiopathic and they're primarily in women, they're just not, but they're not maybe figured out, perhaps because men are often the model for things in medicine, but when there's something that
Mhm.
primarily afflicts women, it's just not maybe figured out as readily. And then the other tricky thing is orthopedic surgeons are mostly men. Like 94% of orthopedic surgeons are men. And that's the modern day statistic. It used to be even less women in orthopedics. Um, and so, there's some study that was done recently that said it would take like over 250 years for the field of orthopedic surgery to kind of equilibrate to the population. So this has been a very slow process. But if you have a condition that mostly affects women, perhaps perimenopausal and menopausal women, being treated by mostly people who won't ever experience perimenopause or menopause or frozen shoulder, I think
Sure.
it's just ripe for maybe not figuring out maybe some of this connection. Not that people aren't trying to take good care of patients. It's just like we all have lived experiences, and the
Hmm.
field itself didn't really have much of that lived experience.
Why is it shoulder specific, or is this every joint? Like, why shoulder specific?
It may be that, I don't totally know the answer to that. It could be the
Yeah, but it's a
density
great.
of receptors, in the
Yeah.
lining of the shoulder, perhaps. But there are, multiple other joints are affected in women in midlife. There's roughly, about 70% or more of women at the menopause transition have joint pain. And we also see an uptick in knee arthritis in women over the age of 50 as compared to men, for example. And women, continue to have greater risk of arthritis, like plain old osteoarthritis, really from the age of 50 to 80. And again, there are estrogen receptors, um, throughout our joints. And, women are more dependent on, women have testosterone, but generally seem to be more like women's bone, for example, is more sensitive to estrogen than testosterone.
Mhm.
But there are other conditions that spike in midlife, lateral hip pain, greater trochanteric bursitis, gluteus medius tendinopathy, whichever you want to call it. That's, much more common in women, for example. Rotator cuff tears are more common in women. Um, Lateral epicondylitis, plantar fasciitis. There's a lot of soft tissue things that are more common in women and become more common in midlife.
Do we see it now more because people, like women, are actually coming to the office and like getting things checked out? Is that like the correlation, or is it because things have changed as a woman? Like, have we decreased movement? Are we, sitting more at work? Is that a correlation?
I think like the disproportionately, if like arthritis disproportionately affecting women isn't new. That's been known for a
Yeah.
long time. The
Yeah.
frozen shoulder being more common in women has been known for a long time. I just think we're sort of maybe digging into it a little bit more. Um,
Hmm.
and I think women have obviously been more prone to fractures for a long time. And it's like, very well known that women are more prone to osteoporosis. But I think like more recently, because of the sort of revisiting of the women's health initiative data, um, and sort of trying to reset the public understanding of safety of hormone therapy, there is now like a bit of a push to sort of, I think, have less siloed care. At least that's one of my goals, is that for people to have um, the ability to sort of connect the dots a little bit more, and maybe have their doctors work together or collaborate, or, like I think there should be so many referrals from orthopedics to women's health, actually. Like
Yeah.
Really?
I
Okay.
send several a day when I'm in clinic. There's so many signs of what's happening, like a 52-year-old woman who has the same level fall and breaks their wrists needs a DEXA scan. They're in the window of opportunity. They maybe want to talk to their women's health doctor about hormone therapy for preventing osteoporosis. So, um, but I do think there is an opening now to kind of have more of that conversation, because the revisiting of the Women's Health Initiative data isn't new, actually. It's just that for some reason, the original press conference in the early 2000s, where there was this sort of announcement with the initial like early misinterpretation of the data, where there were concerns for safety and risk of breast cancer and things like that, kind of took hold, which gets back to like an early version of like where are people getting their health information. It was a press conference. And when the data was actually reassessed and ultimately it was determined that, the treatment with the estrogen did not increase risk of breast cancer. It actually decreased it, and the risk was ultimately found to be a small increased risk, and it was particularly related to use of a synthetic progesterone. It was like too late. The kind of concern was already out. Everyone had stopped prescribing hormone therapy, and the prescription of hormone therapy dropped from like something like 25 to 30% to, very, very low, like 3% or something.
Yeah.
And it's just hovered very low, like well under 5% all these years. And um now there seems to be this new ability to get this message out. And a lot of it is coming to people through pathways like social media. And so I think there is increased opportunity to reconsider, hormone therapy for midlife women, but also look at it with a broader lens. It's always been menopausal hormone therapy has been FDA approved for a long, long time for prevention of osteoporosis, but we're studying more and more about the connections to things like frozen shoulder, joint pain, arthritis, tendinopathies, and it's not one of the, approved indications, but it's sort of like this other realm I think we need to just keep kind of tying together or looking at.
One thing that's common in our conversations on women's health that we've had, and we had a fertility series, we've had women's health series, we've had physical therapists, research professors, is the history of studying active women is not very long. And we always it's not it hasn't been we always bring this up. I remember when the US women's national team and girls in soccer, the women's soccer team blew up in like the late 90s.
Mhm.
And there was the girls sliding, taking the Sherwood sports bra and like winning, and the team won, and there was like this boom in youth soccer for women, and it just girls were playing soccer like crazy. And one of the ladies we had on that studies exercise and um pregnancy, like how active can you really be when you're pregnant,
Mhm.
and there's all kind of this thought process that like when you're pregnant you should sit down a lot, you shouldn't exercise,
It's actually
you shouldn't
better to
move.
exercise in pregnancy. Yeah.
Yes,
Yeah.
yes, it's like go exercise. And like, I've been on social media where like a woman 6 months pregnant, she's exercising, and the comments under it from other women are like, how you shouldn't even have a child if you're going to exercise like that with a baby, that's so inappropriate, and you're putting that child at risk. And I'm like, what are we doing? And like, she studied I think she studied women's soccer, professional soccer, or might have been WNBA maybe, that they considered getting pregnant an injury, they treated it like an injury within women's soccer, and it just that thought just seems crazy to me, right?
Mhm.
Or the research that females are 6 times more likely to tear their ACL. That was really big when I was coming through college.
It's yeah, still a statistic. Some
It's
studies as high as
still
8 times. Yeah.
eight
Yeah.
times, and the reactive forces that are different on women, and is it hormonal? Is it what are the reasons? Why do they tear it so high? And all of these things. None of that research was ever done until I was like college or a little bit after, because I would say
Well,
it wasn't until
athletics
like the
have
90s.
shifted, ever since Title IX, but
Right. Okay. Yep.
been a
Got you.
slow process. I mean, think about your mom. When my mom was in school, there weren't teams for her to be on.
Nope, she didn't play sports. Mm-mm.
Yeah,
Right.
and my mom was really athletic, and she always regretted not really like being able to be on a team of any sort.
Mhm. Mhm.
um, and that's a double-edged sword because I think a lot of women grew up not playing sports and then maybe not being as likely to be physically active as adult, and
Mhm.
that probably
Mhm.
ultimately affected their bone health as they got older. But then there was this window, like my mom did use hormone therapy. I definitely remember her having estrogen pills. It was probably Premarin, and
Mhm.
um, she was probably on the regiment that the people in the women's health initiative were on. So that helped them out. But then you have a new generation that comes in, they're very active in sport. You got a lot of women who are now, moms who tore their ACLs, whatever, 10, 15, 20 years ago, who now have post-traumatic arthritis. And that's a different problem, but they were active as young people, like impact sports with direction change, like soccer, basketball, things like that. They have very good bone density.
Mhm.
um, and maybe some of those people are now coming into adulthood or menopause when they're maybe they will use hormone therapy, so they might have a bit more post-traumatic arthritis, but hopefully they're gonna have good bone density. So there are so many things happening in society and
Yeah.
and medicine that can intersect. But yeah.
I feel like we talk about that a lot because I mean, a lot of our clientele is like 35 to 65, a lot of women. And a lot of the time it is that like, okay, you guys, 3 different decades all lived through sports not being a thing, every different diet there ever was. So like,
Yeah,
I know there's that ridiculous like Vogue article and it's like 1 egg for breakfast and then have a cigarette and then a glass of wine. It was just
yeah.
ridiculous. So it's always
Yeah.
confusion around what should they actually be doing. And I think that's why we find a lot of the time it can be, I don't want to say hard, but like a challenge sometime to work with these women because they are unlearning so much. They are trying to
Mhm.
find like what actually works for them. And I don't know why I never thought about that, but just I think my mom only danced and did cheerleading because that's all she had access to as well. I
Mhm.
don't think she
Yeah.
had any organized sport
Yeah.
as to why it wouldn't like stick in her mind now to be. I know she loves to exercise, but not to, like, regularly lift weights, and for
Mhm.
me, I'm 30, I grew up in a weight room. I started lifting
Mhm.
weights at, like, 14 or 15 in high school, so it
Right.
just seems a lot more regimented now into my brain.
Mhm. Yeah.
Very interesting.
Yeah,
I
so
want you
s
to talk a little bit about your book too, because I know that has to do kind of what we've been talking about, but maybe what you found in your book. I know you said that you co-wrote it with your gymnast friend?
yeah, one
Y'all
of
did
my lifelong
gymnastics to.
friends who is
Yeah,
yeah.
yeah,
Yeah, so my lifelong friend, Sanina Skorsky, is, we were gymnasts together growing up, and then, she went to Brown and was a gymnast there, and I went to Cornell, was a gymnast there, and then,
smart kids.
and I went to med school, I became an orthopedic surgeon, and then she
Yeah.
got a master's at Columbia, so she's an RD and also a personal trainer, and so if you add our brains up, I studied nutritional science as an undergrad, but she's also an RD and the personal trainer, and then I'm an orthopedic surgeon, I have a lot of musculoskeletal knowledge, and so we sort of combined our decades of experiences, which are very complementary, into our book, which is the Complete Bone and Joint Health Plan. And it's just for I one of the things that consistently surprises me when I meet patients for the first time. I mean, the probably the most common question I get that is just super broad is what is arthritis?
Mm,
Um, and one of the frustrating things about arthritis is you can't unwind it. You can't reverse it. I tell people it's like gum recession. If you have a little gum recession and you go to the dentist, you're just happy that it hasn't gotten any worse, but like it doesn't get any less
right.
over time. So we really do need to like take care of our joints, especially if you were someone who is like an athlete and you tore your ACL and you're developing a little bit of post traumatic arthritis when you're like 30. We need to listen to or understand like why are your joints swelling? Like what can you do about it and how can you protect them? Um, and then osteoporosis is people actually confuse arthritis and osteoporosis. They'll ask what is the difference? And obviously they're very related. I mean, arthritis is the wearing down of the cartilage in your joints and osteoporosis is the thinning of your bones and certainly they can be connected in many ways, but they're very different conditions that women happen to be actually prone to both for various reasons. But yeah, we incorporate a lot of dietary interventions, exercise interventions, a lot of non-surgical education, and then just kind of to help people understand their body and like be well educated so that when they do go to a doctor, whether it's their primary care or if they go to a physical therapist or they see an orthopedic surgeon, that they're just equipped with the knowledge to kind of get the most out of that visit, basically. Um, or maybe we can help. Maybe you won't end up in the doctor's office, perhaps. So.
Right.
Mm.
No, and I just like even just having a reference point like that because I love the blend of the brains, like the piece
Mhm.
of let's actually educate about your system, about your
Mhm.
musculoskeletal system, about what you should be doing for your bones and your joints, but then also know that through training and food, that's a big way to actually make you stronger and make you more resilient. And I think that's what I love too, just like with social media now, is that more people are actually educated on
Mhm.
osteoporosis is a real thing and arthritis is a real thing. And it's not just like
Yeah.
somebody is getting it. Yeah.
And I also, I mean, I talk about this a lot. I really think people have to oftentimes thread the needle between these conditions or injuries you have going on. Like our bodies do age. Like we cannot deny that. I do think there's a little bit of denialism sometimes of that, like especially on social media. There's a high likelihood at some point you're going to get some wear and tear in some of your joints, and then you kind of have to respect that. You can't um, be ignoring, like, if your joints are swelling when you are running. I mean, you're not that running doesn't actually cause arthritis. That's not the best example, but like, let's say you want to play basketball because that's how you get your cardiovascular exercise in, but every time you play basketball, your joints are swelling. Like, you may need to adapt and do something different, but the key is to find ways to, like, stay moving. You still have to find ways to get your cardiovascular exercise in, get your high intensity exercise in, get your strength training in. There's a lot of working around aging, I like to say. Um, and I think people just need to be realistic about that. I just don't ever want to be too absolute, like, oh, yeah, forever you're going to be able to do all these things. And you're not gonna be invincible, to be
I saw
honest.
in your bio, there's a lot of, you had a history of ACL, obviously ACL education, ACL talk. Um, when I was coming through college and post college, ACL was a big deal. And like you said, it seems like it's still always on the forefront for with women. It's like, I
It's
feel
still
like
very common.
it's one of those things that, like, the education, I feel like we've never been more we're educating every phase. We're educating more and learning more and learning more and learning more and learning. Yet female ACLs are still on the rise, still on the rise, still on the rise, still on the rise. It's like UCLs in the shoulder with baseball players.
Yeah, and
Tons,
that may be
tons
a
of
function
education.
of that may be a function of exposure to risk. So, there's always gonna
Okay.
be some activities that are high risk, and so the more exposure you have, so the more women are in a sport, the more whatever leagues they're playing in, the more
Okay.
hours play. There is a risk exposure element, for sure. Now, no one has really ever quite solved the question of why are women more likely than men to tear their ACL. And there have been so many theories, like, oh, maybe the notch is smaller, or the ligament is smaller, except for it's kind of proportional to their size, or like a neuromuscular imbalance of the quadriceps and the hamstring firing at different times, um, the way women land or the alignment of their knees. And like, I've done some research on this. If you look at the bone bruise patterns of men versus women, they're actually very similar. So it's probably like not necessarily a different mechanism
Okay.
of injury. Um, there's another study we did recently looking at we make 3D models of knees between men and women, and women's ACLs do appear to be a little bit more vertical. That could be contributing to it.
Okay.
We have a study going on now where we're looking at again, we make these like models of people's knees and put them in these crossing X-ray beams basically, and have them do these jumps. And we'll be measuring their hormone levels, and we'll be looking at how real-time hormone levels may correlate with laxity of the ACL. So it's, we still haven't totally figured that out. Fatigue may be part of it. There's conflicting information about which parts of the menstrual cycle may be more at risk, and so we're trying to get to the bottom of that. But we do know that fatigue in general can be a risk factor for injury, and so that could relate to things like anemia, potentially aspects of the menstrual cycle. So there's some mixed data on whether or not oral contraceptive pills might reduce risk of ACL injury, for example. But then
Talk
there's
about
another
that. Talk
study
about the
where
conflicting data, right? Because
yeah,
I have probably 3 friends of mine that did their master, that, like, when they became a DPT, that their research was around the menstrual cycle and the cycle and women's and injury and its hormone relation. And, obviously the pill has to do with a lot of that. What do you mean by conflicting? What are you seeing
like
on that?
one study that says this and another says the other. Like with oral contraceptive pills, there are some observational studies, showing that um, women on oral contraceptive pills have a lower risk of ACL injury. Then there's another study where they compared women with a Mirena IUD to women on oral contraceptive pills, and there was no difference. So, like,
Hmm.
is it you're just taking like women who are maybe like a little bit more mature, so they're, on contraception, or is it like the pill itself? So again, I don't think we've like actually fully settled that question. But we're looking
Yeah.
into it now, like different hormone um levels to kind of see how that might relate to like real-time ACL laxity to see if we can kind of get some more information on that.
When you look at research, so I have a history in nutritional research was my background originally. There's a difference between reading an abstract and reading research. Like, you know what I'm saying? Like, you know what I'm saying?
Yes.
Reading the abstract in a journal and actually seeing how they put together the study, those are two completely different things, right? I think a lot of people read an abstract and go, "Oh, well, this is what it is because I read the abstract of the
Yeah, you
research."
really can't appreciate like the strengths and weaknesses of a study necessarily from reading an abstract or necessarily how the statistics were derived, or it depends on how much is in the abstract. But yeah, a lot of abstracts sound more impressive than the if you actually read the body. But to be fair, abstracts have strict word counts, and it's very frustrating. You have to like
Sure.
prune away. It's painful to remove words from the abstract
Yeah.
as you've created it because you don't actually want to remove any of the words because you're like, I need
Yeah.
these words, but they have strict word and titles. The titles are so limited. Like sometimes the title isn't even what you want it to be because you would like it to actually explain better what the actual paper is about, but they're so strict on the word counts and character counts.
One of the things I've seen around ACL surgery, some research around like what is actually the long-term outcome of the surgery versus not having the surgery. You've seen some of that some of that research out.
Hmm.
Um, Different kinds of graphs and I feel like every time I'm talking to somebody, they're talking about, oh, they're doing a new way of surgery on my knee. This is a
Yeah, because nothing is 100% bulletproof. So like whenever something isn't 100%, there's always like the newer, better way.
yeah,
I mean,
yeah.
there are advances in that. We're seeing more and more that adding like something extra on the outside of the knee called a lateral extra articular tenodesis may reduce re-injury rates. But the thing that actually is the biggest, most consequential long-term outcome that affects at least half of people with ACL injury is the arthritis, the post-traumatic arthritis that people get. And that's another area of research that I study. Looking at cartilage health and resiliency in people who've torn their ACLs over time. That I work with some of our researchers, our PhDs, Amy McNulty and Lou DeFreight. We sort of combine the biochemical and the um, biomechanical aspects of post-traumatic arthritis developing. But we debate a lot about this graft having a slightly lower V-tear rate than this graft. This one has more anterior knee pain. This one has a little bit more
Mhm.
quadriceps
Mhm.
weakness. This one has a
Mhm.
slightly higher V-tear rate. But when you tore your ACL when you're 15 and when you're 30, the thing that you're really feeling is whether or not you have arthritis in your knee.
Mhm.
And so this is the unsolved problem of ACL injury is post-traumatic arthritis.
Mhm.
And I think it's really the wrong measuring stick to,
Really? Okay.
consider. No, I think, we consider success of ACL surgery whether or not you return to play at the same level and basically made it 2 years without re-injuring your knee. That's what
Sure.
journals ask for. 2-year
Sure.
follow-up, re-tear rate,
Mhm.
return to play, return to same level. How long did it take you to get back?
Mhm. Mhm.
But the thing that impacts your life the most, if you were an athlete and tore your ACL, is, 10 to 15 years after an ACL injury, regardless of whether you had surgery, regardless of whether your, meniscus was fixed, is, 50% of people will have arthritis in their knee. That's half of the people who tore their ACL. And most people tear their ACL like when they're in high school or college. So if you add 10 to 15 years, to a 15-year-old, that's like a 30-year-old or a 20-year-old or a 35-year-old. And, we don't like to consider knee replacements really in people in their 40s. So then you've got people who are used to being really active. Their knee can be quite stable because they had a stabilization operation, but now they're a younger adult with arthritis. And that would be the holy grail of ACL surgery if we could not get the arthritis but stabilize the knee.
Okay.
And so there are some developments in that. I personally think that we should be draining, I always drain the blood out of the joint at the postoperative visit because blood is very toxic to cartilage. So I will drain the blood out rather than leaving this, what we call hemarthrosis in the knee. Um, there are some studies on using some biologic type injections that may help sort of calm the, inflammatory response that leads to arthritis later on. There's something called a BEAR, bridge enhanced ACL restoration, which I also do some research on, that is showing much less arthritis at 6 years out. So, like, you start to see even mild changes on the X-ray that soon. And so, this restoring of the ACL, rather than reconstructing it, is showing some less arthritis in the early phases, but we'll need to continue to follow that through. But we still don't have it solved, and so that is a problem that needs to be solved. And
You think so? Really? You think that is really? I mean, we're going to continue to have these conversations around the knee and
around the
the
arthritis that develops because of the
this
traumatic event. It's the event,
is
the
it
injury that sets it off. So even surgery does not stop that train. It just
okay?
stabilizes the knee. Yeah.
So my limited understanding, and we've worked with a lot of orthopedics where we build and create relationships with physical therapists where we create a lot of return to play that bridge the gap between the clinical rehab and
hmm
actually getting on the field, right? And we built
Which
a
is so
ton of these.
important for not re-injuring. Yeah.
We did a ton of these 8-week programs where we did like hop testing prior and before and landing testing and
hmm
all the field testings they have for that, right? And we tried to measure, the effectiveness of our program. And so I have tons of conversations around knee and ACL, and there's so many times I'll have kids where meniscus tear, right? All right, you can stitch it. It's going to be a longer, little recovery, or you can remove it. And the kids are like, remove it. I want to be back as fast as I can,
That's also
right?
a bad idea. Yeah.
Yeah, and you're like, whoa. And as an older, as a middle guy in my 40s, late 40s, I'm like, hey, let me give you some thought processes on just removing that thing at 17. I know you want to get back to playing baseball, but like you're probably going to be a 40-year-old dude one day, and you're
Yeah.
probably not playing college. So
Yeah.
are you sure? Or is it true? Is there a faster recovery on a patelograph? Not usually for men. Is a patelograph in the ACL a faster?
There's lower risk of earlier re-injury because it is like kind
Okay.
of like a bone-to-bone healing, but then there
Okay.
is greater risk of having some anterior knee pain and
I
arthritis in
don't
the back of
I
your
don't
kneecap.
know a male, and I've had 30, 40, 50 ACLs of kids I know. Some of them are still friends and clients to this day that didn't do a patelograph and go, I got crazy patella tendonitis now.
That had the graft?
Yeah, I had the graft on the patella.
Yeah,
They're
it
like,
does
I got
cause
great.
anterior
Yeah.
knee pain, pain around the
Yeah.
kneecap.
And I'm just
And
like, hey man, that's just kind of like the byproduct of doing this thing, right? Like,
yeah, each graft has its downside, yeah.
yeah. And
Um,
I consider, what's the downside to the hamstring? Is it that the hamstring, now
so
you have
there's
to
slightly
recover the
higher
hamstring?
re-tear rate with the hamstring,
Okay.
but you can, you're a lot of times you get your quadricep strength back faster. Um, And
Okay.
there's different ways to do a hamstring. You can take 2 tendons and fold them in half, or you can take 1 and quadruple it. So you can get a bigger graft if you take 1 tendon and quadruple it than if you take 2 and fold them in half. So there's lots of nuances to things. Um, but
Is
the
that part of your
meniscus thing is
education?
and what'd you say?
Okay. Go ahead on the meniscus thing. Go ahead on the meniscus
Yeah,
thing. Cause
the meniscus situation is I run into this all the time. It's not just athletes. Like, I had a mom who had a bucket handle lateral
Mhm.
meniscus flipped over. She literally came to surgery the day of surgery, said, I can't deal with the rehab from the repair. I just need you to take this out. I have to take care of my kids. My husband works. Um, I think she had 3 kids. She's like, I have to drive them to school. I have to do all this stuff. And her husband was there. And I said, I really need you to prioritize yourself right now. Like, if we take out your whole lateral meniscus, the lateral compartment does not take a joke. You're going to have arthritis so fast in that compartment.
Yes.
It's going to ruin your knee.
Yeah.
And this is a repairable
Yeah.
meniscus, but she was like, this is not even like the athlete situation. This is like a busy mom who was like, I can't take the time to have a meniscus repair. And we had to walk her back
Yeah. Yeah.
from that and be like, no, this is why it's so important that we repair it. And we repaired it and she got through it. But there was just like so much stress in her life. She's like, I
Hmm.
can't devote the time to go through this rehab because if you do a meniscectomy, you just take it out and then there are no restrictions. You can just start walking on your knee normally the next day. You've just got two little poke holes to heal.
Yep.
But if you repair a meniscus, you have to, do your kind of weight bearing on a straight leg for 6 weeks.
Hmm.
You don't bend it more than 90 degrees during that 6 weeks. You're not like, and then you have to rebuild your strength. And there's some restrictions for about 4 months. But um, anyway, we got her through it and it healed and she's doing great. But just the thought of like having to devote this time with these restrictions it's not just athletes, it's anyone who has stress in their life where they feel like they're indispensable or can't miss work or can't, not be there for their kids or doesn't want to
Hmm.
miss part of a season. It's very the short-term easiness of like just taking something out is very appealing to people. So we have to kind of I don't want to twist anyone's arm, but like it pains me to take someone's meniscus out
Does it?
I
Yeah.
because I know
Yeah.
what the result would be. But I've had people who have, demanded that and really wanted that. And it's when it's a child, I really need to talk to a parent, and like
Yeah.
that is really not something I want to do. But if you're someone in spitting distance of a knee replacement, it really doesn't matter. But ultimately, everything is a shared decision making um, between a patient and a surgeon, any patient
Yeah.
and surgeon.
And
And
a
so,
bucket
Mhm.
handle is like I know when that thing flips and catches. I have a friend of mine that just went through the surgery. Like it goes, and there were times like he'd go a week with it normal. He'd be like, "Oh, it feels good. I think I'm good."
yeah, it
Then he'd,
locks the knee.
then he'd step off a curb and be like, "I was walking the dog. This literally happened. I was walking the dog, stepped off a curb, couldn't move. Wife had to come get me." I'm like,
Mm.
maybe it's
Yeah,
time to
it's
think about like getting this thing fixed, right?
yeah.
Like, you know, like yeah, caught, couldn't do it, and it was weird. He figured out that going to a handstand position on the wall released the meniscus, and then he'd go. So he like every day he'd go out and he'd do a handstand and he'd go back in, and he'd be like, "Oh, I think I can hold off surgery for." I was like, "No, dude, this is gonna, dude,
Yeah, it's more
gonna
than
It's
a
a
you're
there's like
Band-Aid.
you're just gonna end up getting
arthritis,
really
not
good
like
at handstands,
yeah.
bro. That's what's gonna happen. You're gonna get really good at handstands, and that's about it,
Yeah, it's
right?
an unusual solution, yeah.
Is that part of is this are these conversations part you talk about educating people and whatever the surgery, especially in orthopedic surgery, right? Are these part of the conversations that you're having with people? Like
Mm,
if somebody comes in and is like, it's a rotator cuff tear, and you're like, hey, here's the pros and cons. You can do the surgery or you can not, and this is what's going to happen. This is what rehab looks like, or this is the options, or explaining them between the difference between the telegraph, the hamstring graft, what's the other graft, the cadaver, like are these
mhm.
conversations you have with people? Are you educating them on these things?
But
Or is
yes.
sometimes or sometimes the orthopedic surgeon's job is to be like, this is probably what you need to do, man. And I'm just, kind of
Well,
like,
there are patients who you can give them all the information and then they just say, "Just tell me what to do." Like, they don't want to make that decision, but, and I always say, "Well, this is what I would do for me," or, "This is what I would want for my child," or, "This is what I would want for my parent," like, depending on where that person is in the phase in life, but it is important for people to feel educated about whatever procedure they're having and or not having, if they make that decision. Like rotator cuff is an excellent example. It depends on where you are in life and what the tear is like. If you're a 40-year-old person with a traumatic tear because you like kind of fell directly on your shoulder or something, that's going to do really well with a repair. And if you don't repair it, it's going to get larger over time and you're going to get um, dysfunction because the ball is going to ride up in the socket and you're going to get something called rotator cuff tearopathy at too early of an age in general. But what if you're 75 and you had a non-traumatic tear that's just been gradually forming over time and we send you to physical therapy and you feel better? Yes, the tear is still going to be there. You may eventually get arthritis. You may eventually need a shoulder replacement, but 75% of people who have non-traumatic tears do well with physical therapy and
mm-hmm,
25% of people don't. And the people who don't
mm-hmm,
may have surgery. But then there are people who your rotator cuff isn't even a good one to repair. It's a terrible candidate. It has
yeah,
atrophy of the muscle. The tendon is way far away from where it's supposed to attach. And we look at the MRI and we say, this isn't even going to work. So I'm not going to tell
Mm.
that person going to have a repair. I'm going to tell them to do non-operative treatment until they need the shoulder replacement. So The problem is people come in with a preconceived notion about like, my friend had this and it didn't work, or my friend did this and it did really
Oh
well. I
god.
read on the internet.
Oh my
And I
god.
always say, like, your shoulder is not the same as your brother's or whatever. And so it's like, where is that person at life? What are their demands? What are their symptoms? What does their cuff look like? What are the chances of it succeeding? What are the alternatives that are appropriate for that person? And so there's really like no one size fits all with anything. I mean, the other classic example is people come in with, a very arthritic knee. It was very obvious on an x-ray, but someone has ordered an MRI of their knee, which of course shows a meniscus tear, because if there's no space between your bones, there's going to be a
Yeah.
meniscus tear.
Yeah.
And they see the word meniscus tear, and they are there to schedule a knee arthroscopy to clean up their meniscus. I have to spend a tremendous amount of time, like 3 times as much time, talking someone out of a knee arthroscopy that isn't indicated. It would be very easy for me to just tell them to have the knee arthroscopy,
Just get it over with.
and it
Yep.
probably wouldn't make them worse, but it's not going to make them better, but it's not the right thing for the patient. Sometimes there's more effort that goes into walking back this sense that a patient may have that they need a surgery that isn't really right, for them. So I always tell people, if a surgeon is telling you you don't need a surgery, you should embrace
Oh,
that.
yes, absolutely.
Like we
Absolutely.
said at the beginning, we like to do surgery.
Yeah.
So if a surgeon is saying this doesn't need surgery, you really don't need
I had a
surgery.
professional baseball player one time go in and he was having some shoulder pain. Like everybody that's pitched in the pros
Like
since they were
every
12, right?
pitcher does, yeah.
Yeah, give me a break, right? Like
At
give me
some
a
point in
break.
their life, yeah.
And he had like a 1 or 2 millimeter tear in the labrum. And the doctor goes, and this is a doctor that's worked with professional guys. He goes, "Hey, if I took all your buddies in the MRI machine, pretty sure a majority of them, we could find a reason to do surgery on a guy who's pitched in pro baseball for 7 years. Like
Mhm.
every single one of them, I could justify. Doesn't mean they need to do it,
Right.
right? Doesn't mean they need to do it. We could, and I've told, and me and the Gray have had this conversation. You could do a full body MRI right now on me, and somebody's
Mhm.
going to find something to do surgery. Like,
I mean,
like
I feel that way.
yeah, somebody's going to find like there's something in there that needs to be cleaned up,
Something unhealed from way
But
back when.
yeah. And my biggest
Yeah.
thing right now is I don't think I could do surgery right now unless you had to put something back on. Like my arm would have to fall off right now for someone to do so, like,
Yeah.
like they'd have to be like, here's my arm. Can you put this back on for me, please? Right. Like, so,
Well, you want, like, if you're going to have a surgery, you want it to be something that the effort you put in, the time you take off, like, it's gonna have a
Yeah.
long-term benefit for you, ideally. Um,
yeah,
what's not great is what I call a long run for a short slide. A
yeah,
big intervention, lots of time where you're having to, like, protect your shoulder or your leg or use crutches or whatever, where you're gonna get stiffness and atrophy, where the treatment may be
hmm
worse, have a larger impact than your actual problem, like something that's gonna give you minimal improvement. So long run for short slide is those are the types of surgeries we like to not recommend.
yeah. I had a
Yeah.
kid one time. I had a parent call me one time and ask me my opinion on something. They're like, hey, the doctor said we could probably do a little quick surgery for this labrum tear, or we could go 8 to 12 weeks of physical therapy and probably have a pretty good outcome. They're letting us decide. I think we're going to do the surgery. I'm like, whoa,
Mm,
whoa, like 8 to 12 weeks, and you don't have to have like they don't understand the damage, like the rehab, the atrophy, getting it back. Like you're going to wish you just did 8 to 12 week surgery on a 15-year-old kid,
yeah,
or
there's
8 to 12 weeks
atrophy. Atrophy
physical
happens
therapy.
very quickly, especially with lower
hmm
extremity surgery. You can be on crutches for a couple weeks and your thigh will just shrink.
Yeah,
Um,
Gray, have you ever seen a knee right out of surgery, a leg, a quad right
I
out of
can't look
ACL
at that.
surgery? No, when you look at a leg, when you look at a knee, you look at girl's knee right out of surgery, you're
Yeah.
like, well, how did that happen?
Oh, I mean, I've torn both quads, and even just
Yeah,
taking time off from tearing
yeah,
both quads,
yeah,
it's
yeah,
very different. It's
yeah.
night and day. I wish I could be a surgeon. I think it'd be I love science, but I can't. I don't like to think about how things work like that. So it makes me
You
kind of
don't
nauseous.
want to see somebody in there. You don't want to see somebody
I
in there
can't.
with a saw, like sawing something
I
like so. Yeah,
I can't see bones pop out of bodies. I
yeah, yeah,
can't see muscles shrivel up. I just
yeah,
ugh.
yeah, yeah.
It's something
Well,
okay, I
else.
don't like to think about how, like, my dad's an eye surgeon. I don't like to think about how that
Yeah,
works.
No,
right,
thank you.
right, right, yeah.
Yeah.
Hey, we really appreciate you coming on. I know your
Yes,
time's
thank you for your
highly
time.
valuable, highly valuable. I really appreciate your outlook as I looked at what the education you were doing. I mean, the first thing you said was like, I do so much education with people and talking to people. That's very refreshing for me. I've had a lot of experience with orthopedic surgeons where I'm just like, hey, orthopedic surgery, they do surgery. Orthopedics, they do
Mhm,
surgery. Like that's their job. That's what they
mhm.
do. You don't get a lot of the education side of it.
It does
But it's
make you
very
run a
appreciative.
little behind in clinic sometimes if you educate
But we
Yeah.
appreciate it, and that's what, like, made your Instagram stand out so much to me too, is not only, like, you're seeing so many different, like, cross studies and just interesting things that we
Yeah.
thought were cool, but just the education piece of it too. Because, like Josh said, I think sometimes you can get an appointment with a doctor that just doesn't explain very much to you, and you're like, "Okay, well, why am I having surgery in the first place?" Or,
Hmm.
"What does my return to play look like? What does
Hmm.
rehab actually look like?" So, it's always
Mhm.
refreshing to talk to somebody that knows the importance of, yeah, the surgery piece if you need it, but the exercise, nutrition, stress management, sleep piece of it too.
Well,
Yeah.
thanks for
So thank
inviting
you.
me. I
Yeah.
enjoyed
Thank you
meeting
very
you
much
guys.
for coming on. Thank you very much.
Yeah,
And we'll should kind of let you know when this comes out and we'll clip it and put it out. And it was very nice. I mean, having an orthopedic surgeon that has that output was very
yeah,
refreshing for me.
agreed.
So thank you very much for coming on.
Yeah, thanks.